the rest of us how they health and benefit from everything that you have given us. We thank you for this in your name. Amen.
Yeah, so our first discussion this afternoon will be on the topic of endoscopy. Endoscopy has to do with looking into the body, the intestines of the body, and seeing what the problem is. It could be for diagnostic or for treatment purposes. To handle this topic, we have the senior lead endoscopist in the Northeast Hospitals. She's one of us here. I'm sure we didn't know that she's such experienced in endoscopy. And she's Sister May McCann. So let's welcome her. She comes forward to give us a talk or a discussion on endoscopy. After her, we'll have another talk, then we'll have questions thereafter before we go to the next topic, if that's all right. Let's welcome Sister McCann.
Good afternoon, everyone. So, my name is May, and I work in endoscopy. So, my background, I'm a clinical endoscopist. Then I have taken over the role of leading the pre-assessment service in endoscopy at Northeast. And I have been very involved with the bowel cancer screening. So, that's as part of our health promotion. I'm just going to present to you the bowel cancer screening program. Okay. So let me just give you a brief history of the bowel screening. Bowel cancer screening program provided by the NHS was launched in 2006 following extensive research which concluded that 1 in 20 people in the UK will develop bowel cancer during their lifetime. It's the third most common cancer in the UK and the second largest cause of cancer deaths, with over 16,000 people dying from it each year. Regular bowel cancer screening can reduce the risk of dying from bowel cancer by 16%. So this is a very significant way to reduce your bowel cancer. So what is bowel cancer screening? So screening is a way of testing healthy people to see if they show any early signs of cancer. And bowel cancer screening can save lives. Screening aims to detect bowel cancer screening at an early age when treatment has the best chance of working. The test can also find polyps. These are the non-cancerous growths that we see in the bowel, which might develop into cancer, usually about 10 years, and polyps can usually be removed to lower the risk of bowel cancer. So, sorry, I'm not a very techy person. So rolling out the bowel cancer screening. Bowel cancer screening was initially offered to everyone aged 60 to 74 who were registered with a GP. In 2018, it was decided by the NHS England to eventually offer bowel screening to everyone over the age of 50. At the moment, everyone between 56 and 74 are invited every 2 years to take part in the bowel cancer screening. Within the next couple of months, this will drop to 54 years old, and by 2025, we are on track to be down to 50 years old. At the age of 74, participants are not routinely invited back to the screening, but can opt back in if they request for another test. So if you're over the age, you can opt back in, and you will receive the kit every 2 years by ringing the hub. So what's the uptake in the Tees area? Teesside has one of the highest death rates from bowel cancer in the country. And we want to change this through education and awareness of the bowel cancer screening program. The national uptake of bowel cancer screening is around 72%, but in our area, it is below 50 in parts of Teesside, parts of Stockton, the center of Middlesbrough, and the center of Redcar are particularly low. Men have a slightly lower uptake, but have a higher death rate than women. This is partly due to being diagnosed in the later stages of bowel cancer. So what you can see on the screen is the kit that we used. It's a fecal immunochemical testing kit, which commonly known as FIT test. Okay? This is a very sensitive test to detect the presence of tiny amounts of blood in the stool that is not visible in the human eye. And it's very specific to hemoglobin, which is part of the blood that is only found in humans. So it's quite common that people who receives the kit mistake the kit as a COVID test when it arrives in their homes, because the boxes are very similar. So in completing the kit, it's very easy. All that is required is to collect a small amount of poo, and this can be done by putting cling film over the toilet bowl, which is to ensure the sample is not contaminated by water or urine. Only a tiny amount of poo is required. So the kit comes in with a wand. Sorry, I'm just having a bit of technical issues. So this comes with a wand that you have to, so you will use the wand to dip the poo to get enough stool to coat the end of the strip. Then you pop it down in a bottle into the prepaid envelope that comes with the kit, and it goes to the regional screening hub that is located at Queen Elizabeth Hospital in Gateshead for processing. So that's what we call the hub. So after processing, if the sample is abnormal, well, that means we detected blood in the stool. Within 2 weeks, the participant will be invited to discuss the findings with one of our specialist screening practitioners. So these are nurses who has got special training to counsel participants who tested positive to the stool kit. And if they are fit for further investigation, they will be invited for a procedure called colonoscopy. So colonoscopy is an invasive procedure, and it can be done, it's usually a day case, and it can be done either with sedation or without. And if you are not fit for colonoscopy, what we can offer is some sort of scan called CT colonography. But we always tell everybody that CT scan is not the alternative for colonoscopy. Colonoscopy is still the gold standard. So this will happen within 2 weeks, and then after having a FIT positive and you've seen the specialist nurse, you decided you want a colonoscopy, then you will be booked within 2 weeks to have the colonoscopy. So we do our bowel cancer screening areas that we do colonoscopy is either at Northeast or Hartlepool. At the moment, we're not offering it here in Middlesbrough, but hopefully soon. So, but we have clinics at Redcar. This is when we see these are the clinics of the specialist nurses. So we can see participants for the specialist nurse clinics, Redcar, Northallerton, Northeast, and Hartlepool Hospital. So just because someone has a positive test, that doesn't mean that they have cancer, okay? What we are looking are for polyps, which are small growths in the lining of the bowel, which if you leave it over time, that could develop into cancer. The polyps can easily be removed during colonoscopy. It is painless as there are no nerve endings on the bowel lining, and this is why you wouldn't know that you're actually growing polyps in the bowel. So getting the kits, sending the kits, they're quite easy. But there are still cases where kits are not reprocessed. So common reasons why these are not processed. So we have to be very careful. And these are the common themes that we have identified. So the sample provided by the participant was not dated, okay? So the date is these tests are date specific. So sample provided was not dated. If the sample is received at the hub, it gets said within 14 days of it being sent out that they can process it. But if it's out of time frame, another kit will be sent out automatically. So don't worry if it goes out of date. There are other times as well where rather than putting the date of where you collected the sample, participants will be writing their date of birth on the sample. So they get confused. They rather than putting the date of the sample, they put their date of birth. So that will not also be processed. Some of the sample dates are smudged or not readable, and the kit needs to be processed within 14 days. If it's more than 14 days, then you need to collect another sample. So there are also cases where kits return the sample with cotton wool or toilet paper inside. This is because some participants think this is like when we do the swab for the COVID, you know, that you have to put the swab back. So again, if you do that, that will not be processed, okay? So delays in completing the kit. Again, I think it's because there's a lot of people using the COVID test kits, and most people get that confused with the fit test. So because of the confusion over the packaging of the screening, because it looks very similar to the COVID test, people just tend to put it on top of their cupboard, and they forgot all about it, and then 14 days have passed, that one should come. You can't use it anymore. Okay? So, I've got a bit more. So, in relation to bowel cancer screening, we are promoting, obviously, bowel cancer awareness. So know your symptoms, okay? Knowing them could save a life, okay? So if you've got symptoms similar to the following, or like the following, so you've got bleeding from the bottom or from the back passage, or you found poop, blood in your poop, or you've got persistent, unexplained change in bowel habits that's more than 6 weeks, unexplained weight loss, extreme tiredness for no obvious reason, and a pain or a lump in your tummy, then I will suggest you seek you go to your GP and ask for medical advice. I think some of these have been covered earlier on, but I just want to reiterate these. I think this was covered when Dr. already talked about, low is higher on the following people. Those who have history of bowel polyps, these little lumps that grows in the bowel. Those who have long-standing inflammatory bowel disease, such as Crohn's, ulcerative colitis, and those who have type 2 diabetes, and those who have strong family history of bowel cancer and have an unhealthy lifestyle. So how to reduce your risk? So we can reduce our risk of bowel cancer by having a good balanced diet with plenty of fresh fruit, vegetables and fiber, plenty of fluids to keep our bowel hydrated, helping it to function correctly. Because I think one of the common things that people tend to do, they increase the fiber in their diet, but they forget to increase the fluid. You need fluids to keep those bowels going. So if you increase your fiber in your diet, don't forget to increase your fluid. Keep hydrated, just like what we learned this morning. How to reduce your risk? I think this was already mentioned earlier on. Avoid processed meat. For example, bacon, ham, sausages, burgers, salami. An occasional treat rather than every day. Limit your intake of red meat to 500 grams cooked per week. Limit amount of alcohol and don't smoke. I think that's... And then also getting yourself active. You only need 150 minutes over a period of 1 week to reduce your risk. Let me also, I forgot to mention actually, what are the benefits of taking part in the bowel cancer screening. So by taking part in the bowel cancer screening lowers your risk of dying from bowel cancer. Screening can also pick up cancers at an early age where there's a good chance of successful treatment. If the bowel cancer is diagnosed at the earliest stage, more than 9 in 10 people will be successfully treated. And screening can find non-cancerous growths in the bowel that may develop into cancer in the future, and by removing these polyps can reduce your risk of bowel cancer. Now, we also say that there is some disadvantages or the risks of bowel cancer, taking part on the bowel cancer screening. So these are what we think are the risks when you take part on the bowel cancer screening. Cancer can be missed. We're not perfect, okay? If it is not bleeding at the time you took the test, the screening test works only if it finds traces of blood. So if the cancer is not bleeding at the point that you've taken the test, it may come as a false negative. Screening, so obviously there's also cases where certain foods, medication can affect the result of the kit. And obviously if you tested positive to the fit, you will be offered to have a colonoscopy, which is an invasive procedure. And if you go and have the colonoscopy, you obviously exposes yourself to risk of perforating the bowel, serious bleeding, adverse reaction to medications. So in terms of health promotion, we do provide health promotion materials. I did bring some, I didn't bring a lot. But if you do want some more, I can bring some more next time. We do health events and focus groups, so opportunities like these, we grab opportunities like these to us to tell everybody, spread the words. We can also arrange endoscopy visits. So those who feeling a bit nervous, because obviously, not many people would like to talk about, toilets and all that, and it's an invasive procedure. some people might worry about their dignity when they're having the procedure, we can organize visits to endoscopy. And there are things that we can offer now that can alleviate your anxiety. So we can give you sedation, we can give you a deep sedation, and then if you don't want colonoscopy, nowadays we're taking part of the pilot. It's what we call colon capsule endoscopy. So rather than having a tube that goes to the back passage, you will ask to swallow capsules like this. So it will take videos, exactly the video that we will see in a normal colonoscopy. So I have been leading our patch here in Tees as part of the NHS England pilot. So we're very proud that we have taken part, and we are on the road to finishing the pilot by December, and hopefully establishing this as part of our service at Northeast. So we here at Middlesbrough Church, there's quite a few of us actually who work in endoscopy. So my brother Hanil Chio, he's actually one of our clinical endoscopists, and he's also one of our senior member of the unit. And we have, as you know, Elder Joy. So if you guys want to arrange visits to endoscopy, we're happy.
Thank you very much. Sounds very interesting, isn't it? We have access to endoscopy in our church. Is that not nice? We thank our sister for that wonderful presentation. Please write your questions down, note them down. We'll take questions and discussions thereafter. One of the things that struck me in what she said is that Teesside has the highest rate of bowel cancer in the United Kingdom. Did you hear that?
Yeah,
she
but
said
also that they don't take part.
Yeah, so she will probably expand later on. Why could that be? So write your questions down, and we'll take questions thereafter. So the next speaker is one of our own speakers here, sisters here. She works in the anesthetic and recovery operating unit in James Cook University Hospital. We work together in the theater. Actually, I see her most of the time, and we say hello to each other. She's going to speak to us on fasting and the medical effects of fasting. Most of us, as Christians, we fast. But are there any things we need to do before fasting, or things to do after fasting? What are the health aspects or the medical aspects of fasting? And we have someone very experienced in that, because most of our patients actually fast before operation. So we'll call on our sister Majuleta Chikuza, to come and give us a talk on effects of fasting. Thank you. Please welcome her.
I won't use the mic because my voice is loud. Hello, church. Well, I think you all know me. My name is Majuleta Chikuza. I work in main surgical theaters at James Cook Hospital, and I'm qualified now about 3 years. And I qualified during COVID. And my first shift, I started looking after patients who had COVID. It was a bit scary, but thank God I'm here. Okay. So today I'm going to talk about the importance of fasting before surgery. I think, as you can see, that's the only slide I gave Uncle Arnold. That's the theater there, and that's the anesthetic machine. And I don't know among members if anyone had surgery. At the moment, thank God I haven't. Sister Anley, so many, yeah? And Ezra, my son, he doesn't even want to see that photo because he had surgery when he was young and he was very scared. So one of the requirements patients are given when they go for pre-assessment is to fast before the day they come to theatre. So for solid foods and milk, it's about 6 hours. So you must stop taking any solid foods and milk 6 hours before your surgery time. And for clear fluids, it's 2 hours, which includes water, black tea, black coffee, fizzy drinks, and squash. And during my time, working at James Cook, most of the time I went checking a patient wherever they are, whether it's in the ward, whether it's surgical day units. We've got our checklist we do. Have you eaten? When was the last time to eat and drink? And the patient will tell you, oh, I just had a biscuit. But all these instructions they were given before. And unfortunately, I'll say to them, I'll ring my theatre, I'll ring the team, I'll ring my consultant anesthetist I'm working with, and the surgeon to see what we can do, but it's highly likely we are going to cancel your operation. So I have realized, even with my colleagues, that people, they don't really understand the importance of fasting. It's not that we don't want you to eat. We want you to eat, and we don't want to starve our patients. But the reason is we are preventing patients to aspirate when we do anesthesia. What do I mean? When you have eaten food, that food, when we put you to sleep, because when we put you to sleep, we'll just not knock you down and just wheel you into theatre. We have to put a tube down your throat. So if you have got food, that food will irritate your stomach and it will irritate your lungs, that food you had. And when your lungs are irritated, you have pneumonia. And I don't think anyone wants to have pneumonia. And once you have pneumonia, you are at risk of being intubated. Then we'll transfer you to ITU. I think I've seen some colleagues who work in ITU. It's not a good place to be because everyone is in bed, mostly they're unconscious and intubated. So that's why we try to prevent that. And as well, for example, fizzy drinks. Someone will say, oh, a fizzy drink is just a drink, it's not food. No, it's important not to drink it because if you drink it, will cancel your operation. That will put you back to the list, waiting list, which is very long, and it will take you time to come back again. So fizzy drinks, they've got carbon dioxide. That carbon dioxide in the fizzy drinks, they can irritate the stomach, that it will cause you to reflux. So once you reflux, that's not good. We don't want the food contents to come up. Then the only thing, if your kidneys are affected, we have to intubate you and take you to ITU. So that's the thing. So one may ask, well, this is what I'm talking about. It's about planned elective lists. People who have been seeing whatever problem they have, and they go all the pre-assessments and they are told your operation is on the 15th of July. These are the patients I'm talking about. But there are some patients who come for elective operation, but they've got problems with reflux. What do we do with that? So, with patients, we have got problems with reflux already, and they take medication for that, and they're coming for an operation, they're fasted. We use another technique called cricod pressure. I don't want you to try it because I don't want you to suffocate yourselves. So we will press here on your cricod cartridge and press it down very hard when we intubate you so that we don't have the gastric contents coming up. So that technique, we use it as well for patients who come to theater as emergency, right? Like my brother said, I work with him all the time in orthopedics theater. And some patients, they'll go out with their friends, right, for a party, they'll fall over, they'll break their ankle, they'll break their hip, and they come to James Cook or whatever hospital, they have x-ray and they say, you need to go to theater now. But they've eaten big meal when they were out, right? So we do what we call rapid sequence induction, whereby we'll put that cricod pressure as well, so that whatever the food they've eaten, they don't aspirate, they don't vomit it. Okay, so that's for emergency. At James Cook, I cover about 19 theaters. If you're an anesthetic practitioner, you go everywhere. You work in every specialty. So different specialty has got different things you do, different airway tubes you use, different techniques. So we cover a lot as anesthetic staff. And as well, we cover obstetrics for ladies who are having babies who come to theater, we cover that. And some of them, of course, they haven't fasted, they thought they're going to have a normal delivery, but something goes bad, they're coming to theater, we do the same, we use cricod pressure. So that's all about fasting. That's why we encourage patients to fast. I know sometimes you are told your surgery is around 10 o'clock, but you know, in theaters, you think this procedure will last about an hour, and it exceeds, and the patients who are waiting, some, they become very agitated, and they are not happy because they have been delayed. No health professional wants to delay the treatment of a patient, but in those circumstances, we only apologize. So after we have waited so long, just be patient until your time is right. Because if you eat a biscuit, if you drink your Coca-Cola or whatever fizzy drink you have, unfortunately we have to cancel you. That's all about my role at Endoscopy.
Thank you very much, Sister, for that presentation. Yes, so we'll take questions for the first two speakers. Sister May, can you come forward? Do we have any questions for them? We have something else to pass on.
Yeah, now that we have, we don't have a microphone here. Oh. We'll take this one here, we'll turn this one back on. I'll take that. Can you take the one on top? Someone wants to ask a question, I have a microphone.
Do you need a volunteer for this little camera?
Oh, there is, it's not really, when we recruit our patients, so there are certain criteria. So these are patients who tested positive on that fit, that is 10 to 100. So if you're having problems, you know, like you have change in your bowel habits, that's, you know, like change in frequency, change in urgency, change in consistency for more than 6 weeks, and you're worried, then you go to your GP, do the kit, and if it's less than 100, then you're a good candidate for the colon capsule. Colon capsule is something that we are I'm personally promoting, because not just the bowel that we will see, the large bowel, we will also see from the mouth, so all of your small intestine, all of your large intestine. So out of the 200 cases that we've done, we've managed to detect 6 cancers. 2 of those would have never been detected by any procedure. CT scan, MRI, unless it gets to a late stage. So we've actually seen a very small lesion in the small bowel.
Mine is not really a question, I just wanted to also compare. It happened to one of my very close friends.
she has got problems with hemorrhoids.
Yes.
So all along she has been struggling. There's so many of us that suffer from hemorrhoids. But she started to see like a little bit of abnormal of how she was bleeding. And this has been going on for almost like 6 months. The sort of a bit of the abnormal bleeding. Then she said, no, let me just go and check with my GP. Then the GP said, oh, just you worrying. But she said, no, this is a little bit too much. She went, and as we talk now, she's actually under chemotherapy and radiotherapy. They detected bowel cancer. So we have to be very, very careful if we're supposed to suffer from hemorrhoids. Sometimes we actually take it for granted to say it's just a bleeding from the hemorrhoids.
Good afternoon, everyone. This is not a question, but I just want to add the answer of the question about capsule and colonoscopy, or actually endoscopy. When we say endoscopy, it's a wide range of nursing and medical area. Endoscopy, I will just want to emphasize it to you. Endoscopy, endo means inside, scopy means visualization. So it means visualization inside of your body. So you can have a bronchoscopy, you can have a cystoscopy, you can have that one, but that's all endoscopy. And this afternoon, we specified it to colonoscopy, right? So yes, we are promoting that capsule endoscopy at this time, and May Machan, Sister Machan is the one who piloted that one in Northeast, and not only in Northeast, but in this area. So it's a wide caption of that. But as what we knew, camera with the tube is the gold standard procedure at this time. Because once you see a polyp in a capsule endoscopy, you need to come back for colonoscopy to remove the polyp. Okay? But when you do colonoscopy straight away, if there's a polyp there, we can remove straight away. So it's better to remove the polyp because we can classify the polyp as there's two kinds of polyp. There's a hyperplastic polyp and adenomatous polyp. A hyperplastic polyp, that polyp, it doesn't turn into cancer. But the adenomatous polyp, it will turn into cancer after 5 to 10 years. Right? So it's better to remove that polyp while it's still benign. So colonoscopy procedure, though it is an invasive procedure, but still it is a gold standard in doing colonoscopy. And regarding about the hemorrhoids as well, so yes, we don't take for granted about hemorrhoids. There's stages of hemorrhoids, stage 1, 2, 3, and when we do the PR examination, when they examine with the finger examination at the back passage, they can feel that one, but proctoscopy is the best way to examine it so that we will know what stages of hemorrhoids that a patient has that time. Okay, and it can be cured with with the ointment that we put it into our palm, and sometimes we do banding for the hemorrhoids. It depends upon what stages of that hemorrhoids, and the last sort is an operation of the hemorrhoids. And avoid straining, avoid sitting long period in the loo, in the toilet. Don't bring when you go to the toilet, don't bring your mobile phone, don't bring any newspaper to it, because what you have to do in the loo is just do your business and come out. The more you strain, the more you develop hemorrhoids.
All right. 2 questions, one for me and one for you. So, can't I just walk into, can't I just book an appointment with a GP to do a colonoscopy routine for prophylaxis? Do I have to wait till I have hemorrhoids or bleeding or change before I ask for a colonoscopy? That's the question. Second question is, if you have a patient that is going for surgery and probably is hypertensive or diabetic and taking regular medications, what do we take the drugs before surgery and all that? How do we do that to avoid what you talked about, aspiration?
Okay. I don't know if I get you well. You said if a patient is hypertensive or diabetic. Okay. So for a patient who is diabetic, they are always the first one on the list, so that the fasting period is not too long. Because if we put them as number 3, it might be long. So they are the first one on the list of any surgical list, no matter which specialty. And while they are in the ward, or when they are male SAU surgical unit or female SAU, they have to take their blood sugar and let us know as anesthetic staff when we go to do the checklist to know their blood sugar. Then when they come to theater, we'll take the blood sugar as well. Once we put them on the table, it all depends how was the first one. If they are on insulin dependent, they will have what we call GKI, insulin solution. So if they are on insulin, if their blood sugar is below the level we have to give them that insulin, it all depends because we've got different ranges. That's the first one. For hypertensive, our nurses in the wards, because we take patients from different areas of the hospital, so wherever they are, it's either surgical day unit or at the ward. The nurses who admit those patients to come for surgery, they need to record their initial blood pressure so that we know. Because my blood pressure, it might be a normal to me, but it's high for someone. So if they miss that, it's difficult for us, although we'll go back to the records to see what it was. So as anesthetics, we check the blood pressure throughout the surgery, before, during, and after, even in recovery, as recovery ODP.
So the short answer to your question is we don't do prophylactic colonoscopy for the simple reason that this is an invasive procedure. So you have to weigh up the risk and the benefit. Okay, so there's 3 ways that you can have colonoscopy. So it's either through our symptomatic list. So these are the people who's got symptoms. So you can either be referred via your GP. So if you've got symptoms, you go by your GP and you will be referred by what we call the typical pathway. So this is the cancer pathway. And then you will then be offered to have a colonoscopy. If you feel that you don't want colonoscopy, sometimes we can then offer you a CT colonoscopy. Apart from the symptomatic route, there's also what we call the surveillance branch, where these are the patients who are already known to have polyps. So they have to come back every 3 years, or if depending on the size of the polyps and depending on the biopsies, it's either a year or 3 years. And also, if you've got like hereditary conditions like Lynch, things like that, that predisposes a person to having lots of polyps, and obviously if you've got polyps, that predisposes you to cancer. So you can then, even though you don't have any symptoms, you're going to get called back sometime, depending on the frequency of your surveillance, then you get called back. There's another way as well, it's obviously the screening. So these are the non-symptomatic people. So these are just, of a certain age that will be, you can participate. Then if you're tested positive, then you'll be invited in one of these clinics. You can talk about colonoscopy, and if you don't want colonoscopy, they can then offer you CT colonoscopy. If you had the initial diagnostic colonoscopy and we find that you've got polyps, or you've got sometimes even cancerous up to 5 centimeters, then we can remove it endoscopically. We are now more and more doing sort of like state-of-the-art endoscopy procedures that we are saving a lot of our patients having surgeries. So we can remove up to 5 centimeter rectal polyp under deep sedation, so we give them propofol. So it's not like general anesthetic, but one step close. So we don't like to use general anesthetic in endoscopy, but we save a lot of these patients from having major surgeries.
I just want to add on hypertensive or hypotensive. If a patient is hypertensive or hypotensive, when they come for surgery, we might choose, it all depends with the consultant anesthetist I'm working with, we might choose the infusions to keep the blood pressure at a certain level. So, i.e. mitral infusion.
Thank you very much. Thank our sisters for that part of the section. We're going to the second part, which is inviting one of our senior community nurses. She works in the Northeast Hospital Trust. She's Sister Charity. She'll be speaking to us on falls. There are very many people that fall. How do we prevent falls? How do we take care of people that have falls? What do we do about people that have falls, especially the elderly? She's going to give us all that talk. She's quite experienced, and let's welcome Sister Charity, please, to speak to us about falls.
Hello, everyone. Good afternoon. I'm Charity. I work in North Cheese Hospital, and I also work for Stockton Borough Council. My background, I'm a physiotherapist, but I had to go for some extra, a little bit of some training, so that at least I'll be in the role that I'm doing. So I work for multidisciplinary service, which is Stockton Council North Cheese Hospital, and I also work for the Falls team. So we call it MDS, the multidisciplinary team. The MDS and the Falls team for Stockton Council and North Cheese, we just merged into one. So I've put these stands, the two of them. So each time when there is like voluntary sectors, when they are doing awareness courses or awareness just to the public, or even whenever we are being called to present to just the public, it's either 2 of us or even more, but normally it's 2 people, so that at least there's not more that are being taken out. So each one of us, either I can talk for MDS or I can talk for the Falls. But because this is a massive topic, Falls service, I'll need almost like an hour really to go through it. But this one is a new thing altogether, the MDS. When I'm saying new, it started almost end of 2015 with the Better Care Fund that was given from the government to North Cheese Hospital and Stockton Borough Council. So you only find this MDS in Stockton Borough Council and also in North Cheese Hospital. Can you move next slide, please? Why? This is an integrated service for the social care team and also for the health team. We are tired of trying to stop the boat at the mouth of the river, like before it goes into the lake or the sea. So we said, enough really trying to just do the falls, because the criteria for falls, we need the person to have fallen. We just don't go for falls if the person is not fallen. So the person should have fallen. So can you see the tactic there? But with our new MDS, we are not even waiting for the person to fall. When the person falls, to us it's too late. We need to go when there are now indications for that our person is already failing. So this is to prevent patients needing long-term care. Prevent unnecessary hospital admissions, I will explain. Prevent readmission into hospital. Provide patients with a community support plan. So we are looking here at the criteria. I know some of you will say, I'm not yet 65, but having the knowledge is better than not having it. So when people are 65, that's where sometimes people even start even earlier on, starting to have problem, frailty. You know, people are starting to, to develop so many problems. So what we have done is North Cheese Hospital, working in conjunction with Stockton Borough Council, our GPs, they now have what we call prescribing link officers. So these people, because there are so many of our community people, they don't even go to the GP. You know, you ask them, when were you last at the GP? Oh, but 2 years ago. Then he said, okay, no, I know you cannot just go to the GP when we don't have a problem. But our prescribing officers, what they do, they go in, anyone who is 65 and above, they visit and they start to pick problems. Starting, these people are starting to have problems. And most of them, they need very basic. I'll tell you one, getting out of the bath. When somebody has got a shower over the bath, just lifting your leg over, that's when so many people fall. Or sometimes just getting off the toilet. When the toilet is very low, when they try to come up, they just stumble. Then you just ask, how did you fall? I came out from my toilet and I fell. Or they are really in very low sofas. By the time they come up, they fall. Very small issues like that. Or sometimes they'll tell you, I was taking my bin from the backyard to put it at the front. That's when they fell. Especially when it's ice, when the weather is not good. That's when they fall. So we are targeting these people. Those ones, so that's why I'm talking for MDS today. We are targeting 65 and above who are starting to have little problems. Can you go for the next slide, please? So when we say we are trying to avoid unnecessary admissions into hospital, so we want to get them so early. If they need any equipment, we give them equipment, maybe like equipment, when I say temporary equipment, it's just like a toilet frame to raise your toilet. If it's a grab rail, we put grab rails in the bathroom so they can have something to hold on. If we now find they are having problems in taking, trying to climb over the bath, we can just put a shower board where they sit before they can actually go into the bath. So simple things like that, that's what we are. And somebody who is already starting to struggle to bring a bin from the back to the front of the door to the property, now we put them under what we call care for your areas. So the Stockton Borough Council, when they are coming to take the bins, those people, all that they do, they just arrange the bins at the end, at the back. Stockton Borough Council staff will come to the back and then they carry the bins away. So simple things like that. Then we also have problems. Can you go next slide, please? We also have problems that are being discharged from the hospital. Some of them, they can be discharged early. And then when they come, environment in the hospital, and when you go home, totally different. In the hospital, the nurses, everyone is saying, hello, sister, how are you doing? And everyone is cheering up for you. When you go home, it's almost like a boom, everything changes. So it's almost like a crisis. By the time you go there, their mobility has changed. You just say, were you working in a hospital? Yes, I was working. This person cannot do anything. Sometimes by the time it could be the second day, they're already brewing, whether it's a UTI, urinary tract infection. So many things that can happen. So things like urinary tract infection, we can liaise with the GP. It's not something that a person should be admitted for. So we can liaise with the GP. If it's just declining mobility, then it's another crisis. We have to bring all the equipment that we can manage to get, and then we can also refer them for a short-term package of care. Now we are getting carers in. Like the first year in the morning, our presenter talked about the last place you want to be in, unless it's necessary, is the hospital. One, there's a lot of money that the government has to pump in for a patient just to stay overnight. Imagine if they're going to stay 5 nights. And then the hospital again, there's a lot of what we call hospital-acquired infections. When you see it, you think it's sparkling, it's so clean, but there's a lot. You will discover that somebody was okay before they went into hospital. By the time, about 5 days later, you hear, oh, they've got a chest infection. By the time you open your eyes, they're already in ITU. The pneumonia is worsened. So the last place we want our patient to be is the hospital. So as much as possible, we want to treat everything in the community, not at the hospital. But when it's a proper crisis, when we can look to say, no, this patient now needs the hospital, then we have to dial 111, then the ambulance can come and take the patient. But in most cases, we are now dealing with clients at home. But like what I said, we need to start right from the top of the river, not to go when it's about to enter the lake or the sea. We also deal with financial issues. Why financial issues? People have got so much poverty. Some people are not even aware of the benefits that they can actually get from the government. So we liaise with them. Some people are struggling even to pay bills. So we'll ask them. So our document for assessment, it can take even up to about 2 hours. Whilst we are doing an assessment, and the assessment should be done in their own environment, because when we go to see them, we are assessing right from the garden. We want to look everything. So the assessment, when it goes, if it's that they're struggling with financial issues, we refer them to our welfare rights. Then they will check whatever benefits that they can get, and if they are they meet the criteria, then they have to be boomed up. And because it's we have referred them as our team, everything that they get, it has to be as soon as possible. Because why? We are trying to not to let this patient be admitted. If we go into a house which is cold in winter, there's some, sometimes we take it for granted. When you can put your house under, when we've got central heating. Some people, you walk in, you say, how are you surviving with no central heating? When it's like that, what we need, we put SOS to a fire brigade. They'll come straight away with all heaters for every room where they stay, just to make sure that our client is safe. Then we start working everything else so that at least our client is safe at home. So we also talk about even things like gardening. Sometimes you go for these people who are starting to fail. By the time you go there, you wonder, is there anyone in this place? The grass is almost like this. So for us to start, we need to start from somewhere, because we know our client is already failing. If we try to let them do the garden, they're going to have a fall. And this is what we are trying to avoid. So because now this MDS is now catching them before they even fall. So Stockton Council has got gardeners who are very experienced. So they will go on to do all the gardening for them. Then after that, mind you, we are already liaising with our welfare rights. They can get what we call attendance allowance. By the way, attendance allowance has to come as soon as possible, because we don't want this patient to be in the garden. If they're going to the garden, they will have a fall. Or even cleaning the house. If we know if they're having problems in cleaning the house, we'll let them hire a cleaner from the Stockton directory, then our client, so that pocket of money, and I mean it's a lot of money, nearly £400 a month, somebody's being given just for that, to say, if you can help yourself, so that at least they can actually cater for themselves, for the gardeners, for the cleaning the house, for the window cleaners, for just a little help, like even somebody who will come and help you just to do your shopping. So these are some of the things that Stockton Council and North Cheese Hospital. So it's not anywhere, it's only in Stockton, and only with Borough Council Stockton as well, just around Stockton area. It may be rolled to other, like councils and areas, but for now, from 2015, it's only at North Cheese Hospital. It's not even Hartlepool, because North Cheese Hospital and Hartlepool, they are one trust, but this fund only came for Stockton. So we are almost the pilot study since 2015, and it has really saved a lot of money by unnecessary admission. And our GPs, they're so good. I have to thank them, because once you realize with them over the phone to say, I work for such and such, I've got a client here, they are presenting like that, we need this patient to be seen, because what I'm seeing now, it's already a crisis. It's almost, I'm in between now. I'm in between the falls and the MDS. It's no longer the criteria that we wanted. But again, our GPs are so fast. The GPs, they've got, some of the centers, they've got like a GP who is on call, who only runs for those sort of scenarios. They'll come straight away, look at the patient, prescribe, get their medication, they are at home. I'll give you a scenario whereby I went to see a patient and I couldn't believe it, they didn't have any bedding. And I'm asking, why don't you have any bedding? They said, oh, when I let my niece cleaned everything, doesn't have it. The only thing that was there was a duvet cover. And I said, please, can I have your neighbor to come? The neighbor came, and I sent the neighbor to town to get some bed linen. And unfortunately, he had swelling everywhere, especially on his legs. And I'm saying, have you seen your GP at all? No, my GP, when I call, they never answer the phone. I think everyone has actually gone through that experience. So I had to make sure that the GP was involved. The GP came and the patient was supposed to be admitted, but no, we saved. So we have a lot of crises, especially after our COVID. Lots of people have deconditioned. So what do? Lots of people suffer from isolation. That's one thing that I had not mentioned. So we work so much closely with our voluntary sector, whereby we have got lots of social groups. Every area, whether Billingham, Stockton Central, we are talking about Eagles Cliff, Yam, they've got loads. You'll be so surprised how much activity groups that are taking place. So if we realize our patients are isolated, what do? You do have transport. If they say, I don't have, then there are volunteers again in the community that can actually take these clients to these activity groups. If we see they've got deconditioned in they are deconditioned in their muscle groups, we send them to what we call Ontego training classes. These are centers, and we also run some of them whereby you can have a 12-week program while you are doing balance and strengthening exercises. So I would say, in a nutshell, this service that I'm trying to promote is actually to avoid falling at home. Before we even talk about fall, we want that whereby we catch our client as soon as we see signs that they are starting to fail. And we try to involve the family, the friends, as much as possible, so that our assessments are very holistic. Before I sit down, our team comprises of social workers, district nurses, physiotherapists, occupational therapists. So the occupational therapists, some of them have worked in the community for a long time. Some, like me, were brought from proper acute services, and we have got also nurses that were brought from acute services. So when you go out, you never get stuck. You go there, if you feel this thing is overwhelming for me, all that you do, you excuse yourself, you phone the department, I'm having a crisis, I need some help. So you get all the help over the phone to say, do this, do this, do this. You can see one client, when I first joined them, I said, oh, I've come from to people who are very lazy. I was coming from where I could see 20 to 40 patients a day. And in this department, you can see one patient and you struggle the whole day to try and meet the needs of that client. You have got about 15 referrals that you have to do as soon as possible, because our tenure, we are only supposed to be doing everything within 48 minutes, 48 hours. So after 48 hours, as far as our department is concerned, you're already late for our client. So everything has to move very fast. Wherever we send our client, we just tell them we are from the MDS. What we are trying is to prevent this patient being admitted into hospital, and they will do everything so quick. So in a nutshell, that's all that I can say about MDS. Next time I can talk about falls, I need an hour. Thank you very much.
Thank you, Sister Charity. So that she had a lot of information for us. I mean, prevention of falls is very important because if not, you end up coming to us. I've seen many clients that were walking their dogs, especially during the winter, and either the dog pulled them or the dog was too fast for them and they end up falling. Or in the bathroom, I mean, the house is slippery, so it's very important. Well, let's keep our questions for her and we'll talk. So the next topic is about low back pain, which is something very common amongst us. And we have someone very experienced in it. Sister C works in the Northeast Hospital as a physiotherapist. Please welcome Sister C to give us a talk on low back pain. That's our last topic for this afternoon. Please welcome her.
All right, shall we all stand up? Yeah, because physios don't like people standing up. We like you to be active, so just give yourself a good stretch. And for those who are able, just try and reach for the skies. Put it down and just roar up and feel that back stretch. Thank you very much. I'm Sim, as I've been introduced. You can sit down now, thank you. I work as an Endoscopy physio practitioner in the musculoskeletal service, and I'm going to talk about back pain, low back pain. And low back pain is one of the most common things that I have to deal with on an every single day basis. Maybe that's my bread and butter. So, next slide, please. I would like 10 children, please, to just come to the front. 10 children, quickly. I haven't got much time being the last one. I get the last end of it. So 10 children, please just come up. All the children, just come up. Or have they grown older already? Right here to the front, come and join me here, right at the top. Okay, let me not call your name. 3 girls at the back. Just stand up in a line. If you know you're slightly older than this, please get yourself here. 1, 2, 3, 4, 5, 6, 7. I need 3 more. 3 more. 3 more. Sophie and partner here. And Zayn. They must have low back pain at the speed at which they're walking. So slow. Quick. Okay. Hands up. Anyone who's ever had back pain in their life, low back pain, should I qualify? Because there's a difference between upper back pain and lower back pain. So if you've had low back pain in your life, hands up, please. Right. So quite a few hands going up. All right. So what we really know about low back pain is count yourselves. 6, 8.
6, 7,
10. So what we know is 8 in 10 people at some point in our lives will have what? Low back pain. So how common is that? It's like having a common cold, right? Yep. What we know is only maybe split him in half and 1 or what will actually have what we call serious back pain. So most of us will just have what we call common back pain. Thank you very much for your attention. So as you have heard in the morning, we are fearfully and wonderfully made. Our backs are really, really strong. A lot of bones in there. I'm not going to go into the anatomy of it. But I think, you know, if someone says to you, you've got a banana backbone, how do you feel? How do you feel? Not nice. Not nice. In what way? Because your back is supposed to be solid. Okay. So, back pain, really, we classify it into different. When you've got the acute back pain, you bend down to pick something, that is kind of acute. And then maybe you did that, and then it's like coming into 2 weeks, 3 weeks, maybe coming up to 12 weeks. We kind of call that some of stuff acute. And then after 12 weeks, it really becomes more of chronic pain. And we do have a lot of types of mechanical back pain, just like you can have whatever, all I've got a cold is affecting one of my muscles, it's affecting one of my nose, or I'm sneezing, or what. Basically, we're just saying you've got a sprain or a strain in your back. So I won't pick up on any of those types then, but there's different types of back pain, but most of them really nothing major to worry about. Next slide, please. And I want to dwell on this because this is what I deal with on a day-to-day basis. So when patients come to my clinic and complaining of back pain, we always ask them, what are you expecting from me? And the most common thing is, I want a scan. I want a scan. And I said to them, well, why do you think you need a scan? Also that I know what is wrong with me. Okay? Now, when we look at these figures here, these are figures done on a research, done on people that were just picked off from the street. They were not complaining of back pain. So we call them asymptomatic studies. And a lot of us have heard, like, oh, my GP told me that my back is crumbling, my discs are all worn out, I am now bone on bone, and all sorts of things like that. But if you really look at this study, what is found, so what's the average age in here? 40? 50? Let's just look at 50-year-olds for just comparison's sake. So how many 50-year-olds, if they have an MRI done, come out with a disc showing degeneration? 80%. And remember, these are people that we've just picked off the street, never had back pain in their life, never complained of it in their life, but 80% of them, when you do an MRI, will say degenerative disc. And most of us would have heard, oh, you've got a big disc bulge. How many 50-year-olds will have a disc bulge without even having any symptoms? 60%. And in my line of work, more often than not, somebody comes in and they're complaining, I really had that big disc bulge a year ago, I'm really having bad sciatica right now, I want an MRI, I'm not leaving your office until you've done so. And I'm like, yes sir, and I do one. And guess what comes out? The radiologist will come in and say, actually the disc from L45 from the MRI done in 2018 has resolved. It's put itself back in place. And then we've often been told, oh, you've got lots of wearing and repairing there. So I'm talking about facet degeneration. Again, go to our 50-year-olds. How many of those without any back pain can have facet degeneration? 32%. Without any symptoms at all. So what am I saying? Low back pain? You might as well call it a common cold in your back. It is quite something that happens quite commonly. And like I said today, it's probably just 5 to 10% who will actually have serious pain, serious condition that will need us to do more than what we actually do on a daily basis, which is your exercise, your posture, what you eat, your thoughts, your emotions. I often laugh at myself because if Whitney calls and she's busy whinging on the phone, the next day I can tell you I'll wake up and I'll be like, why is that? Because my thoughts and my emotions are not right. So back pain is a complex condition that we find not necessarily defined by the biomedical stuff, which is the MRI and stuff like that that we find, but a lot of your social factors, a lot of your emotional, a lot of your psychological factors and everything else that goes with it. And the best line of everything is your back is stronger than what you think. And what's the difference between this guy and me? Why is it that I can't pull my little car with my back? What's the difference?
Practice.
Attitude of mind.
Attitude of mind, yeah? I can't hear.
Way to do it.
Say that again.
He is not afraid.
So that's attitude of mind. No fear. Yeah. But what else? Training. So apart from an acute back pain where you do something and the back pain just comes on straight like that, there's been an injury or something like that, most of us with back pain that has been there since before Jita was born, basically what I need to do is strengthen my back. Yeah? These guys can pull these tracks here because they've trained. They've reconditioned and conditioned themselves to the point where their back can practically do anything. And we know with our patients, the people that have come back and they've really had bad sciatica, and people who couldn't bend down, people who couldn't do anything, we rehab them, and they all of a sudden can pick something off the floor without even thinking about it. Because when you feel strong in yourself, you also feel strong in your attitude. And I would just want to go at the things that, remember that 5 to 10% of the back patients that I said these could be serious conditions. I'm just going to go through what we call red flags. The first one there is trauma. Obviously, if you're falling from a height and you've got massive back pain, you can't just sit at home and hope that it will go away. Go and get it checked. And the older you are, yeah, if you are somewhere where I am now, females especially, or if you've got a history of osteoporosis in yourself or in your family, then if you've had trauma, you've been knocked down by something and you've got massive back pain that is not improving, we need to go and get it checked. The second thing there, back pain lasting more than 3 months, and this back pain started before the age of 45, and you've got battle pain to go with it, you've got a lot of stiffness in bed, but once you get up and move about, the back pain gets better with movement. It gets better when you take ibuprofen or naproxen. Then it's most likely that it is an inflammatory kind of back pain. That is different from our common cold. This is more like the flu of back pain. You need to be seen for that. So we call that a red flag. The third thing we've got there is urinary retention or loss of bowel or urinary control. You know, the way that we were talking, I was on yesterday about, you know, how we know that there is a God there, not evolution. And I was mentioning that, you know what, up until the time I started having nerve pain, you don't actually think that you've got electricity flowing in your body. That's how fearfully and wonderfully we made. So when you have pressure on your special nerve bundles, that kind of gives electricity to the groin region, yeah, to the saddle region where we sit on. If there is any little problem in there, you'll have what you call the quadrilateral equina syndrome. Now, this will affect your water weights, your bowel weights, and sometimes in men, the only symptom you could have is sexual dysfunction. So don't ignore these symptoms. Because when you do have, if it does stand out that you do have this quadrilateral equina, that is a surgical emergency, you need to have surgery. Otherwise, you lose control of your bladder and your bowel for the rest of your life. Number 4 there is if you've got back pain and also have a fever. That is a red flag. Because what it could mean is that you've got actually an infection in your spine. So you need to have that done. So you've got back pain, yes, yeah. Sometimes your heart rate might go up, but you've got a back pain, massive back pain, and your temperature is skyrocketing, you need to go and get that seen. And the next one there, fever, night sweats, you're very, very tired, you are just losing weight. I don't mean 1 gram a day. I'm talking about a lot of weight, so suddenly, and you are not actually intentionally wanting to lose weight. That is a red flag. We've got a lot of organs in the pelvis, but also if you've ever had a history of cancer, whether it be breast, whether it be kidney, whether it be bladder, and you're having a lot of back pain, and you are also having all this, the fever, the sweats, the fatigue, you need to be seen, because sometimes you can actually have what we call metastatic spinal cancer. So these are the things that we want you to be watching out for back pain. If you are developing any of these, it's a panic button, you need to go and get that seen. And next, I would like us to take time to just watch a little video. There are a lot of things that have been said about back pain, but I'd like you to listen to this video, which is done by people with experience dealing with back pain, to just let us understand a little bit more about back pain. Thank you.
Persistent back pain can be scary, but it's rarely dangerous.
Persistent back pain can be distressing and disabling, but it's rarely life-threatening, and you're very unlikely to end up in a wheelchair.
Getting older is not a cause of back pain.
Although it's a widespread belief and concern, getting older causes or worsens back pain. Research does not support this, and evidence-based treatments can help at any age.
Persistent back pain is rarely associated with any serious tissue damage.
Backs are strong. If you have had an injury, tissue healing occurs within 3 months, so if pain persists past this time, it usually means there are other contributing factors. A lot of back pain begins with no injury or with simple everyday movement. These occasions may have contributions from stress, tension, fatigue, inactivity or unaccustomed activity, which can make the back sensitive to movement and loading.
Scans rarely show the cause of back pain.
Scans are important, but only for a minority of people. Lots of scary sounding things can be reported in scans, such as disc bulges, degeneration, protrusions, arthritis, and so on. Unfortunately, the reports don't say that these findings are very common in people without back pain, and that they don't predict how much pain you feel or how disabled you are. Scans also often change, with most disc prolapses shrinking over time.
Pain with exercise and movement doesn't mean you're doing harm.
When pain persists, it is common that the spine and surrounding muscles become really sensitive to touch and movement. Importantly, the pain you feel during movement activities reflects how sensitive your structures are, not how damaged you are. So it's safe and normal to feel some pain when you start to move and exercise. This usually settles down with time as you get more active. In fact, exercise and movement are one of the most effective ways to treat back pain, and having a health professional coach you through the process can be helpful.
Back pain is not caused by posture.
How we sit, stand and bend has not been shown to cause back pain, even though these activities may be painful. A variety of postures are helpful for the back, and it's safe to relax during everyday tasks such as sitting, bending and lifting with the round back. In fact, it can be more efficient.
Back pain is not caused by a weak core.
Weak core muscles do not cause back pain. In fact, people with back pain often tense their core muscles as a protective response. This is like clenching your fist after you've sprained your wrist. Being strong is important when you need the muscles to switch on, but being tense all the time isn't helpful. Learning to relax the core muscles during everyday tasks can be helpful.
Backs do not wear out with everyday loading and bending.
The same way lifting weights makes muscles stronger, moving and loading make the back stronger and healthier. So activities like running, twisting, bending and lifting are safe if you start gradually and practice regularly.
Pain flares don't mean you're damaging yourself.
While pain flares can be very painful and scary, they are not usually related to tissue damage. The common triggers are things like poor sleep, stress, tension, worries, low mood, inactivity or unaccustomed activity. Controlling these factors can help prevent exacerbations, and if you do have a pain flare-up, instead of treating it like an injury, try to stay calm, relaxed and keep moving.
Injections, surgery and strong gel are usually not healing.
Spine injections, surgery and strong drugs like opioids usually aren't very effective for persistent back pain in the long term. They come with risks and can have unhelpful side effects. So finding low-risk ways to put you in control of your pain is the key.
To read the full paper for free, search Back Pain Facts BJC. If you'd like to watch the patient stories behind the facts, click the link in the description.
Thank you very much.
Thank you very much. We'll take questions now from. Do you have any questions for the two speakers? Yes, otherwise.
The video anyway,
there's no mention of carrying excess weight.
Absolutely. I think it's one of those things that you know if you're in clinic. It's one of those topics that you think, should I not mention it? But fortunately, a lot of patients that come into my clinic now say, I know I'm overweight, and then I can say, yeah, even I know that I need to lose a stone or so, and people can start opening up about it. And for things like, so for instance, for knees, I then give them this illustration that, well, I read somewhere actually that if you put on 4 kilograms of weight, it puts about 4 kilograms of pressure on your knee. Actually, so weight contribution, think of it, your back has got small little joints. So if you're getting pain, if your pain in the knee gets worse with putting on weight, think about those little joints in your back. So weight management is one of those big things that we don't talk about as far as managing back pain is concerned. Thank you.
I had back pain for all of my life. Since I was 27, I suffered with back pain. And I don't think it was mental. And I wasn't overweight. But since I'm retired, I'm getting better every year. So does that tell me that my job was the wrong job in my life?
I can't say that it was a wrong job because you were a nurse and that was productive work and stuff like that. But obviously it's the things that we do while we're at that job. So for instance, when for years I just worked as a physio, and then when I moved to this specialism, I'm more sedentary than I was as a physio, and I found that I got a lot of back pain from that. So now what I have to do is every single lunchtime I've got to walk around the hospital, because backs don't like being in one position for too long. So some jobs that we do, so people with manual jobs, for instance, they do get quite a lot of back pain coming in associated with the job. But it's what you do, it's about rehabbing you. I can't say to anybody with a manual job, just leave that job and go and do something else. Because then you're going to die of stress and financial things that come with it. But it's managing where you are with it. Get proper rehab with it. Talk to your occupational health. They can manage certain things for you. Those who are in the offices, you know, like your displays, training equipment, your chairs and stuff like that, those can be modified for you. If you're doing a job where you're on the ward and hands-on and stuff like that, follow all your manual handling protocols and stuff that they tell you, because that's going to help you to ease back pain. And if you do still struggle, talk to your manager and say, you know what, I've got a problem with your back. And we're in the NHS, we understand each other much better. They will then make sure, well, do you get lighter duties? Do you get transferred to work in a different ward or in a different department or anything like that?
Yeah, and then they send you to elderly care.
They send you to elderly care.
I actually wanted to also respond on that, especially people who actually work in healthcare setting. Even if the patient, you cannot handle that patient, they don't do any risk assessment. Even if risk assessment training has been provided, manual handling is provided, people will just close the curtains, they'll just look who is watching and what. The patient, it doesn't happen overnight. It's a repetitive thing that you actually do. Whenever people, I used to work in acute, whenever people used to close curtains or chat, you are going to I would say, no, I'm not. I'm looking after my back. So, and people will be very angry because doing that is so quick, within a second we're finished. But trying to get the equipment is going to take them about 20 minutes, so they want a quick fix. But quick fixes in life, especially when you talk about manual handling, it has got massive effects, you know, afterwards.
Sorry, they have glide sheets and everything, right? And then they run out of glide sheets. And then you do it the comedy again. You know, that's annoying.
Thank you.
Yeah, so we thank everyone for making today's program a success. We hope that in the next Health and Temperance event, probably it might be outdoor. I mean, probably the next summer we'll do it outdoor and experience nature. thank you everyone for being here. Part of what we preach today is about rest. We need to go home and rest after now. So we'll take the last verse of the hymn we sang. Elder Joe will give us the closing prayer. And as we step out, we could do the blood pressure checks as we step out and go home, so that we don't have to wait here. Thank you very much, and God bless us. Sister Jessica, could you help us with the song? Can we rise, please?
Would you be free from your passion and pride? There's power in the blood, power in the blood. To Calvary's side, there's wonderful power in the blood. There is power, wonder-working power in the blood of the Lamb. There is power, wonder-working power in the precious blood of the Lamb. Would you do service for Jesus the King? There's power in the blood, power in the blood. Would you live daily His praises to sing? There's wonderful power in the blood. There is power, wonder-working power in the blood of the Lamb. There is power, wonder-working power in the precious blood of the Lamb.
Let us pray. O most gracious and kind Heavenly Father, Lord, we thank you, Lord, for a wonderful experience once again that we heard from the health ministry department, the things that we realize that we take for granted, Lord, from small back pain to a little fall, and to those who are ignoring the symptoms of bowel habits, and also the importance of following fasting, Lord. These are the things that we have tackled today, Lord, and we thank you for giving us the opportunity. And let us be a good example as well, Lord, to the people around us, that whatever you have told us and teach us, Lord, we will be able to show to others as well. And as we are going to finish our program this Sabbath day, Lord, may you protect us as we travel home. Keep us away from any harm and danger, Lord, and especially from any illnesses. And bless those who are not here, Lord, that are not able to join us. Once again, Lord, thank you, and let us be ready for the working week that is ahead of us. Let the light that is coming from you, Lord, the light that they will see through us, Lord. Thank you so much, Lord, for hearing our prayers, and please forgive our sins. I pray in Jesus' name. Amen. Thank you, everybody.